Okay, so good morning everyone. Today we will start with our 4 weeks seminars on breast radiology. Every Sunday we'll have a talk presented by Dr. Chra about the breast MRI, and every Wednesday I will present something also related to the breast. So for our first talk, our first Sunday, Dr. Chra will talk to us about the breast MRI. She has made a beautiful presentation, detailed in fact, which I recommend every one of you to pay attention because it is so important. Okay.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. Thanks for your attendance. My name is Ahmed D. I'm Senior House Officer of Radiology. Today I'm going to present my seminar, which is on a breast MRI, supervised by Dr. Ahmed D. First of all, I would like to talk a little bit about the introductions of the breast MRI. Breast MRI is indispensable modality. Breast MRI, it's indispensable modality, along with the mammogram and ultrasound. It can't replace neither mammogram nor ultrasound, as each of them have their own advantages and disadvantages. And it has a higher sensitivity for the detections of the breast lesion, especially the occult one and then mass enhancing lesion. That's why the breast MRI uses it as a guidance for taking the biopsy from this lesion, I mean the occult one and then mass enhancing lesion. The history of the introduction of breast MRI returns back to 1918, independently by Hay Wang et al. And both Kaiser and Zedler. Requirements for the breast MRI. Breast MRI need a full strength of 1.5 Tesla or more, should not be less than 1.5 Tesla. And the patient's position should be in a prone position as it is shown in this picture, with the breast hanging in the recess of a breast surface coil. The advantage of this position is that letting the breast tissue to separate freely and decreasing as much as possible the motion artifact that occur during respiration.
Just one note, please go back. First of all, normally, routinely, during our practice, we use this position but head first, not feet first. So it's the opposite way. The head is going first into the machine, not the feet. I don't know why it's drawn like this, because I don't think anyone uses feet first for breast MRI. We might use feet first for knee MRI, for ankle MRI, for foot MRI, pelvis maybe, but I don't think breast is possible. First. Second, if you notice the breast coil is something like this. You can see the coil. Can I point at it?
Yes.
Yeah. This is the thing, the breast coil. Okay? This thing, of course, it varies between manufacturers, but the basic idea is this appearance.
Yes.
So it prevents us from doing MRI for obese patients, someone with a big belly. If you notice, she cannot fit in this thing. إذا كرش كبير, it's very difficult for the patient to lie down and go inside the machine with the coil in prone position. So this is one of the limitations of breast MRI. Another limitation is pregnant women. You cannot make someone who's like 7 or 8 months pregnant do this position and go in the machine. So this is kind of a problem. And third thing, when we put the patient in this position and it's head first, always the patient should have a cannula in the hand.
Yes,
in
for
the
the
hand,
contrast
not
administration.
here. Because when she's prone inside the machine, her hands will be showing from the opposite side. So you can give contrast from the opposite side in the cannula. Don't forget the cannula before the patient is in the machine.
In this picture, it shows a dedicated breast surface coil. These are two types of the breast surface coil. The open one, which is on the left side, and the closed one, which is on the right side. The most modern ones is the opened one. I like to tell you that the breast surface coil are used for increasing the signal to noise ratio, and every single surface coils are composed of a number of the channels starting from 4 in number, and the most modern one composed of 16 channel or even more. The advantage of these channels is that to increase more the signal to noise ratio and also the spatial resolutions of the image.
And the increased number of the channels helps get a little bit faster images. It's not that much difference, but more channels, little bit faster speed.
Yeah.
And the other thing that every one of you need to know, you cannot have a 16 channel coil where your MRI machine is 4 channel. You need a 16 or 18 channel MRI machine and 16 or 18 channel MRI coil, breast coil, surface coil, okay? You can have an 18 channel MRI with 4 channel coil. You can do that. A coil 4 channel will machine 16 or 18 or 12 or 8, whatever, no problem. But you cannot have a 12 channel MRI, a 12 channel coil on a 4 channel MRI, okay? So the machine should be equal or more to the number of channels in the coil. And when you are buying an MRI machine, this is one of the things you need to pay attention to, because some companies and some engineers, they take advantage of that. They sell you a 12 channel MRI machine with 4 channel coils. You don't know, okay? And you lose all the advantages of your nice MRI machine because your coil is a low channel number. So you need to make sure the number of channels in the coil is as much as possible, considering the number of channels in the MRI machine. Get it?
And this is a dedicated or a special tool used during the breast MRI guidance biopsy taking. As you see here, there is a fixation tool and a special tool for taking the biopsy. Sorry. And a special tool used during taking the biopsy, and also the computer-aided targeting, as is shown in this picture, in which tell you the exact site for the introductions of the needle of biopsy, whether in which of the squares, and also whether it's cranially or caudally in every single squares.
So the mainly, just go back to the go back. This thing. What they do is that they press the breast in this grid, and they do the MRI, and you see the lesion, which square the lesion is, and the computer tells you just go through the second square from top, go for like 2 centimeters and take your biopsy.
The square in the grid is the same as in the monitor.
Yes,
It's computer
exactly.
aided.
So you can see where to take the biopsy, and this is used mainly for lesions that are only seen on MRI.
Yes, the All-Cont-1 and mass
You
enhancement.
cannot see it in the mammogram or the ultrasound. So you go for MRI guided biopsy, which is really expensive because you need needles and stuff that are not made of it.
And these are all tools used during the biopsy taking. The requirement of the breast MRI also using a contrast administration here is the gadolinium chelate, which shortening the time of the T1 and leading to a higher signal intensity. Dose is 0.1 millimole per kg of the body weight, and the flow rate is 2 mol per second. The contrast medium bolus should be also used, which flushed with 20 mol normal saline. About the breast MRI protocol. The breast MRI protocol is evolved from an abbreviated MRI protocol to a multi-parametric breast MRI protocol. I'd like to show you the schedule about the breast MRI protocol, showing, first of all, T2 weighted image taken before contrast administration, and also diffusion weighted image, which accompanied by the ADC, and also T1 weighted image.
Use the pad to show. What is it? Pointer. Laser. No.
Okay.
Yeah, exactly.
Okay. Here is the T2 weighted image, diffusion weighted image, accompanied by the ADC also, and T1 weighted image before contrast administration. After contrast administration, we are going to take a multiple acquisition. First of all is the ultra fast. The ultra fast only can be taken with a machine of 3 Tesla or more. And the series of the T1 weighted post-contrast are taken for the dynamic evaluation. If your machine is 3 Tesla or more, the ultra-fast can replace the long acquisition time. I mean series of the T1 weighted image for the dynamic evaluation. The abbreviated protocols for the breast MRI. I'd like to tell you that the breast MRI protocol is changing according to the indications of the breast MRI. For example, if we have a breast lesion, it's better to take a multiparametric breast MRI protocol as it's shown here in this schedule. But for the abbreviated breast MRI protocol, it's used during a screening. Also, the abbreviated one, I would like to say that it is only 2 acquisitions taken of the T1 weighted image before and after the contrast. It's better to be taken at 90 seconds after the contrast, because most of the breast lesion will be at the peak of their enhancement during this time. And the other sequences improve the discriminations of the breast lesion with the preventions of a false positive and a false negative classification.
What do you mean by screening MRI?
Screening MRI, it means this is an indications for the breast
You
MRI.
know, for
Some
the
of
screening mammogram.
Yes.
But can we use MRI for screening?
Yes, also.
Why?
I will talk about later on in the indications of the breast MRI
Good.
in the next few slides. Here's a delay phase dynamic evaluation. Delay phase dynamic evaluation is essential, especially for the new adjuvant chemotherapy, to detect the presence of a residual ductal carcinoma in situ, in which there is a breast lesion, and we will give a new adjuvant chemotherapy to the patient. In order to evaluate the response to the new adjuvant chemotherapy, better to do a delay phase dynamic evaluation for the patients by the breast MRI. Although the ultra-fast imaging, as I mentioned before, that's only be taken with a high field strength MRI machines, can replace the delay phase dynamic evaluation acquisition. Delay phase dynamic evaluation can be done also with the ultra-fast. It's okay if you're taking the ultra-fast and also delay phase dynamic evaluation, but if you have ultra-fast, you can just depend on the ultra-fast. I will talk about the ultra-fast and the delay phase dynamic evaluation later on in the next few slides in detail. For lesion discrimination, T2 weighted image and diffusion weighted image accompanied by the ADC imaging is very important, required for more discriminations of the breast lesion. Here in this picture showing the T1 non-fat size suppressed and T1 fat suppressed pre-contrast and T2 fat suppressed pre-contrast and T1 fat suppressed post-contrast. Of course, the T2 weighted image, diffusion weighted image, and T1 weighted image better to be done with the fat suppression. As you know, the bulk of the breast tissue are fatty tissue and fibroglandular tissue. Better to make a fat suppression for the breast before doing this acquisition. T1 weighted image. It's performing with or without fat suppression, but better to be done with the fat suppression. And image acquired are in the axial plane better than the sagittal plane. Why? Because in the axial plane it is faster acquisitions and better overview of both breasts at the same time. Native T1 weighted acquisition should be prior to the contrast administration. After the contrast administration, T1 weighted acquisition should be taken at 60 or 90 seconds. Why? Because most of the breast cancer show peak enhancement at this time. From native and post-contrast T1 weighted image, we can obtain the subtraction image. And multiple subtraction image, we can after fat suppression, we can obtain maximum intensity projection, which help in detections of the lesion rapidly. And what's the disadvantage here of the motion artifact and a chemical shift and a poor fat suppression, making you to miss the small lesion even by the maximum intensity projection. So even with the maximum intensity projection that's very sensitive for the detection of a very small lesion, you can also miss them or obscured by the motion artifact and chemical shift, also poor fat suppression. About the T2 weighted image, including in the standard MRI protocol, the T2 weighted image without fat suppression allow better depictions of the lesion morphology because it shows the fat content and also the water content. But a T2 weighted image with fat suppression enables easy visualizations of the breast cysts. A mass with a high signal intensity in T2 weighted image mostly are benign, which may be apocrine metaplasia, cyst, myxoid fibroadenoma, fat necrosis, and lymph nodes. But mass with a low signal intensity in T2 weighted image mostly is malignant or cancer because of high cellularity and low water content. Some have high signals and are malignant, like a metaplastic cancer or mucinous carcinoma or necrotic cancer.
So we are mainly looking for lesions that are hypointense on T2 fat saturated image.
Yes, mostly concentrated.
Hypointense.
Yes, hypointense. And what's important here is that T2 weighted image will make more discriminations of the breast lesion. You have to depend on the other acquisition in order to figure out the final discriminations of the breast lesion. T2 weighted image is used for the detection of the edema, perifocally or prepectoralis, in which lesions with the edema mostly malignant and has a poor prognosis. T2 weighted image in several studies improves the specificity of the MRI for differentiation between the benign and the malignant lesion. Diffusion weighted image. The diffusion weighted image that quantify the movement of the water molecules in the tissue, which depends on the cellularity and a microtexture of the tissue. Achieved by applying a motion sensitizer gradient replacing to an T2 weighted image. The spin echo, a T2 weighted image, that's a spin echo in which giving a pulse 90 degree and then 180. Echoplanar imaging has a single shot and also multi-shot acquisition. I'd like to ask from Dr. Ahmed to clarify a little bit more about the echoplanar.
As I told you before, this is a very complex physical topic. It's mainly storing the data from the whole excited tissue in the what's called K-space. That's the space in the computer for storing the different signal strengths. So echoplanar imaging is a way to make this happen fast, let's say. There are different types. There are single shot and there are multi-shot. Each one has its own advantage and disadvantage. The basic idea is that you use diffusion weighted images to detect water molecule motions. Are the water molecules moving freely like the normal tissue, or is it restricted in diffusion? Is it crowded and held up in the tiny space? Inflammatory lesions, breast cancers, of course, it's just like the brain diffusion, the same idea. Whenever there is edema, there is restricted diffusion. The water molecules cannot move, and that's why it is shown in diffusion weighted images. And you need to correlate with the apparent diffusion coefficient mapping, the ADC map, to confirm that it is a really restricted diffusion and not a T2 shining through artifact. Why the T2 shining through artifact? Why does it happen? Because this diffusion weighted image is basically a T2 weighted image. So it is affected by the different variables that affects the normal T2 weighted image. So if the lesion is, for example, a cyst, it will be hyperintense on diffusion and hyperintense on ADC. So it's hyper, that means it is not a real diffusion restriction, it is a T2 shining through artifact. If it is hypo-intense on ADC mark, then, and hyperintense on diffusion, then this is a real diffusion restriction.
Cancer show high signal on diffusion weighted image means it's decreased diffusions because they are high signal. To get adequate diffusion weighted acquisition following are crucial. First, appropriate B value and adequate fast suppression. Minimizations of the artifact is sufficient for getting a high signal to noise ratio. Apparent diffusion coefficient is a quantitative measurement of the diffusion weighted image. Values are usually expressed in 10 to minus 3 millimeter square per second. In cancer, because of prevented diffusion, ADC are generally low and has low signal and intensity in ADC map. And it's about 0.8 to 1.3 multiplied by 10 to minus 3 millimeters square per second. For a benign lesion, compared with the malignant one, is more ADC value. 1.2 to 2 multiplied by 10 to minus 3 millimeters square per second and have relatively high signal intensity. Diffusion weighted image and ADC, some notifications important to put in mind. These ranges are changed according to the numbers of the B value. Higher B value yield a smaller ADC value and lower B value yield a higher ADC value. For the diffusion weighted image performed by using a B value of less than 1000 millimeter per second, and showed the greatest accuracy in distinguishing between the benign and malignant lesion. In considering the ADC, B value of 0 to 800 millimeter per second is recommended for clinical practice, providing sufficient diffusion weighted image and acceptable signal to noise ratio because large B value causing decreased signal to noise ratio.
So in the brain MRI, we look for higher B value.
Yes.
While in the brain diffusion, we're looking for higher B value.
Yes.
While in the breast diffusion, we need a lesser B value of 800.
Yes. And diffusion weighted image with the ADC can be used after contrast material administration, but better be performed before the contrast administration, as the contrast material will make more signal intensity for the lesion. But adequate fast suppression is critical in diffusion weighted image. First of all, to minimize the echoplanar imaging related artifact to the ghost artifact and chemical shift. And also measurement of the ADC will be underestimated if the fast suppression is inadequate. Ultra-fast breast MRI image, as I told you before, can be done only with machines having 3 Tesla foot strength. Document the early inflow. What's the ultra-fast breast MRI? It documents the early inflow of the contrast material into the lesion. What's important of this character is that the malignant lesion enhances earlier and faster than the benign one. So the first lesion enhances first is more suspicious lesion. And most breast cancers enhance within 10 seconds after the arrival of the contrast material in a major vessel, I mean the aorta, whereas the benign lesion will begin to enhance within 15 seconds, a little bit more.
So the idea, the first lesion that enhances is suspicious
one.
This is the idea.
Yes.
أول واحد يضوي.
Yes, this is the most suspicious lesion,
suspicious.
and that's why the ultra fast image can replace the delay phase dynamic.
But are you sure it's only in 3 Tesla? I think it can be done in 1.5, the ultra fast.
Here.
Well,
Okay.
you're
The lesion.
teacher. Okay.
The lesion can classify by using time of enhancement relative to that in the descending aorta, and the maximum slope of the enhancement curve is the is used for the dynamic evaluation. An accurate determination of these parameters requires very fast imaging technique, 5 seconds for whole breast volume. And this can only be done by view sharings and compressed sensing techniques at the 3 Tesla, which is not feasible in all MRI units. By this way, the ultra-fast image will provide a dynamic evaluation of the lesion without a requirement of a long acquisition time, which provides similar accuracy for the lesion characterization. Here's the figure showing the ultra-fast enhancement of the lesion, ultra-fast imaging, which show the dynamic enhancement or the early enhancement of the lesion. As you shown here, this is the beginnings of the contrast administration. After 10 seconds, the aorta will be enhanced. After enhancement of the aorta, which is a major vessel, the lesions start to enhance. The malignant lesion usually will enhance within 10 seconds, but the benign one starting to enhance more than 15 seconds, as is shown here in these pictures. After 30, yes, 38. It means more than 15 seconds after the aorta. After the aorta, yes, but the malignant one within 10 seconds after the aorta enhancing, and this is the slope of increasing the enhancement of a malignant lesion, the red one, and the green one is the benign lesion. If you notice, the slope is a little bit shallow, but this one is more steeper. So that's why if you have ultra-fast image or acquisitions, you can depend on it for the dynamic evaluation of the lesion. Dynamic evaluation. Dynamic evaluation is done with the time signal intensity curve. With the time signal intensity curve, I will show you later on. Investigate what? Investigate the permeability of the vessel that supplies the lesion. This done by taking series of the T1 weighted acquisition within 5 to 7 minutes after the contrast administration. Type of the vessel, according to the dynamic evaluation, is divided into 2. Leaky vessel. What are the leaky vessels?
Just one clarification. It's taking series of T1 acquisition within, not after. So you start the acquisition and you finish within 5 to 7 minutes, not after 5 to 7 minutes. If you do it after 5 to 7, contrast is gone and there is nothing. So you inject contrast, you start acquisition. The acquisition will take somewhere between 5 to 7 minutes. يعني مو تنتظر 5 إلى 7 دقائق يلا تسوي الاكوزيشن. لا، تعطي الكونتراست وستارت خلال 5 to 7 minutes you finish the dynamic.
Automatic.
إيه طبعا it's automatic. بس إنه when to start? After 5 to 7 minutes? No. You start and finish within 5 to 7 minutes. Be careful of that point. Don't understand it wrong.
Yes. After contrast administration at 60 to 90 minutes, the first T1 post-contrast is taken. 60 to 90 seconds. Yes. After that, series of the T1 weighted image will be taken for dynamic evaluation. Dynamic evaluation, according to the dynamic evaluation, there are 2 types of the vessels: the leaky vessels, in which the contrast media reaching to the peak, then remove it from the lesion rapidly. And less permeable vessel, enhancement still increasing, that's seen in the benign lesion. And this curve can be replaced by scrolling over a series of the post-contrast image. It means that you can, depends on the scrolling over the series of the image that taken after contrast administration. Here's the kinetic curve assessment. In a kinetic curve assessment, there's 2 phases, the initial phase and the delayed phase. Initial phase within first 60 to 90 seconds after the contrast administration, or until the peak enhancement is reached. Determined by comparing the intensity in the first post-contrast image to the intensity in a pre-contrast image. Here, in this phase, we will compare the enhancement of the lesion to the pre-contrast image. And in a delayed phase, which coming after the initial phase, I'll show you here, delayed enhancement phase, after 19 seconds, series of the image are taken, in which a curve will be produced, as is shown here. Use it to describe, according to the shape of the curve, we are describing the lesion, whether it is malignant or it is benign, and the washout of the contrast from the lesions can be evaluated here according to this curve. Here, this curve showing the blue one, usually considered a benign, or it's called a persistent, and it's usually considered a benign or not bad, maybe malignant.
Persistent enough.
Yes, the persistent one. Maybe malignant, especially for the ductus carcinoma in situ and the lobular breast cancer, which is diffuse growing breast cancer. And the green one, as shown here, is called plateau. Mostly they are suspicious or bad, and maybe benign, especially in case of lymph node lesion. The red one, which called the washout curve, is suspicious or it is bad. 85% of them are malignant lesion and manifest with the washout phase, maybe benign also in case of a lymph node, as shown here.
So basically a lesion is either persistent, plateau, or washout.
Yes.
The more you go from persistent to washout, the higher probability of
this
malignancy.
malignancy.
basically كل ما ينزل البوستون delayed enhancement كل ما تزداد the probability of malignancy.
Here, multiple images. Instead of the curve, you can use it by scrolling over them, showing a persistent kinetic curve. If you looking to this image, the enhancement of the lesion, if you notice that it's increasing with the time, it's not decreasing or it's not in the same enhancement level. So this is called a persistent kinetic curve, and they are going mostly with the benign lesion. Here in this picture, showing a lesion, here in the first one, second one, and third one, have the same intensity, it's not changing, and this is called a plateau. Mostly they are suspicious or bad lesion, but can be benign as it's in the lymph node.
Lena, what is this image?
It's plateau.
No, not the type of the curve. What is the image? T1, T2, T3, T4, fast saturated, not fast saturated, axial, coronal, sagittal. Describe this image. The image. Subtraction. يعني T1 لو T2. T1. 3 low post contrast. Fast saturated, low non fast saturated. So you have to mention all of them. This is a T1 fat saturated post contrast subtracted breast MRI. إذا عندك multiple images, then you say dynamic. Like here, if I show you one image, you don't know whether it's dynamic or not. You say just T1 fat saturated post contrast subtracted sagittal or axial breast MRI image. شو تعرفين؟ That's your job to know. ما دام post contrast لازم يكون T1. ما دام T1 لازم يكون الفات هاي. هذا الفات لو. ليش؟ لأنه subtracted. Okay. Continue, please.
Washout kinetic curve. Enhance initially to reach to the peak, and then I'm giving a small impression about the washout kinetic curve. Enhance initially to reach to the peak, and then it will decrease intensity of the enhancement after 2 minutes. Contrast will be washout. Here in this picture, as shown here, the intensity is decreased in the third one in comparison to the first one, and this is called the washout kinetic curve. Computer-aided volumetry image or computer-aided detections, as shown in this picture, it's purely kinetic evaluation, and it does not evaluate anatomy of pathology of the image, and it is automated kinetic energy. It means that without looking to the kinetic curve or scrolling over the image, you can take an idea from this computer-aided volumetry that the lesion is malignant or it is benign. It's giving you an idea about the dynamic evaluation. It can do a multiplanar reconstructions and subtractions very well and fast. It is good for measurement, for the measurement package.
يعني ببساطة المكان مال كل ما تختار ليجن وتشوف الكيرف مالته وتقرر تختار ليجن وتشوف الكيرف مالته. Some place ممكن يكون فيها 20 lesions, 30 lesions, benign or malignant or whatever. You do the color coding. The computer see the enhancement of each part and gives it a code color, and you know here the red one
The red one
that has the highest enhancement. So this is the most suspicious. Okay, and you always have like the Doppler, you have a map for the colors. Like the red is highest enhancement and the blue is the lowest enhancement, or you can change the color code as you like. So the idea is يعني مكان ما تشوف وحدة تشوف كل البريس تسوي.
It's faster.
It's faster, and if you miss something, إذا تشوف you miss something, this will help you not to miss anything.
Indication of breast MRI.
I think we should stop here and we continue next week because it's a heavy breakfast. Okay? So we'll continue next week. Thank you very much. It's amazing. Any questions?